Good. Thank you very much. A change of gear. I suppose back to the first world to some extent, although I hope that some of what I have to say is applicable to the developing world as well. My title, The Pursuit of Excellence, A Pediatric Cardiologist's Perspective. There are many phrases that come to mind when we talk about the pursuit of excellence. Evidence-based medicine, what is the evidence base? World's best practice. The issue of the learning curve, which is familiar to all. What do we mean by excellence? The dictionary definition says that excellence is the quality of being exceptionally good, a quality that confers superiority. This may, of course, apply in research, in relation to clinical skills, technical ability, in procedural tasks, teaching. Perhaps the most important of all, of course, is the question of excellence of outcomes for patients. We are, after all, judged largely by the outcomes, and our aims must be to minimize risks to patients, and to maximize benefits. And to some extent, that's exactly what we've been hearing about. We must, of course, work to improve safety, and we must remember all the time that patients and their families quite rightly fear what we are going to do to them, because there is a very high frequency of errors, especially in high technology medicine, multidisciplinary medicine, the sort of medicine that pediatric cardiology and cardiac surgery and intensive care and interventional catheter procedures inevitably involves. We've already heard the quote, "First do no harm, primum non nocere," which has been attributed to Hippocrates and is sometimes said to be part of the Hippocratic Oath, but actually is not. Probably in its present form it originated with Thomas Sydenham in the 17th century. It's actually difficult to achieve in the current interventional era for pediatric cardiologists. Inevitably, we do take some risks with what we do. We cannot do the things that we do without taking some risks. Michael Rigby this morning said that interventional catheterists are intrinsically risk takers. What about the issue of evidence and the evidence base? The evidence base is not new. Dr. Withering, in his account of the foxglove in 1785, documented in detail the doses of digitalis that he had given to a large number of patients, the effects that it had had, both good and bad, and he detailed his recommendations on how digitalis should be applied safely. Unfortunately, with that evidence, as applies to much of the evidence that we have today, those who followed him seldom read his guidance in any detail, and even less often followed it. Even in recent times, the use of digitalis has been somewhat random. One pediatric cardiologist, to my knowledge, in the 1960s was recommending that if the infant did not improve on the initial regime of digoxin, then you should double the dose. That was not evidence-based, and it didn't do the patients any good. The practical problem that we all are well aware of is that many doctors have employed traditional dogma, dodgy rationales, shaky evidence, often anecdotal, as justification for decision-making. Personal experience has been used as a basis for management planning without any rigorous attempt to look critically at the evidence that's available from the literature. However, evidence itself does have to be viewed carefully and critically. If we looked at the mortality of the arterial switch operation compared with that of a Senning operation in the early era, we would see some frightening evidence. The Great Ormond Street team in the year 2000 looked at these issues, the problems of introducing a new operation, and how you view the obvious evidence during the early era of the arterial switch, very much higher mortality than that which had been experienced for many years during the Senning procedure. I think nowadays we would all accept that the arterial switch is a much better option. The learning curve, as was evidenced on that last slide, is something which has tended to be accepted in many centres as being almost inevitable in the introduction of new procedures. However, we should not accept the idea that that learning curve is inevitable and is something that our patients have to suffer as we master these new techniques. We need to find ways of making sure that those of us who are adopting new techniques can do so applying the highest possible standards and keeping patient morbidity and mortality to a minimum. And we should not all be adopting these new techniques until the leaders in the field have pioneered these procedures, have brought down the morbidity and mortality to acceptable levels and proved that they work. Let's have a look at the different ways that evidence is acquired, the different levels of evidence. This is the evidence pyramid, at the top of which are a rather small number of meta-analyses and systematic reviews, going down a slightly larger number of double-blind randomized controlled trials and cohort studies and case-control studies. And of course, as we get lower down in the evidence pyramid, the volume of evidence increases, but its quality declines. And nowadays, we accept these different levels of evidence, but we have to recognize that the vast bulk of the evidence is down here. What are we to do when the irresistible force of the need to offer clinical advice meets the immovable object of flawed evidence, as it so often does? All we can do is to do our best and give the advice, but alert those who we are giving the advice to the flaws in the evidence on which it is based, and to recognize that ourselves. Don't fool ourselves into thinking we know all the answers. This comment from a very recent article in the British Medical Journal was not in relation to pediatric cardiology, but it might well have been. The evidence base is weak and comes too late for evidence-based policy making, and unfortunately that remains true at the present time. What about this term, world's best practice? It doesn't mean the best in the world. You might think it should, but it actually doesn't. The current definition is current recommended practice, and it refers to a standard of practice that is achievable by conscientious and able physicians and surgeons with appropriate levels of training and with access to the research and evidence base that applies to their work and to the individual problems of their patients. So let's now look at our goals in seeking to achieve excellence. We need to ensure optimal training and continuing education, CME. We need to encourage critical review and discussion of literature, the evidence. We need to audit outcomes on an ongoing basis and to compare with results from other centres. Audit. We need to make our treatment decisions after appropriate interdisciplinary discussion, teamwork. We need to work together, as Jane Somerville said in her presentation earlier in the day. Cardiologists and surgeons are complementary, not competitors. Collegiality. And we need to avoid adopting novel strategies without careful planning and a research base. That's experimenting on patients. We need to avoid trying out something new because someone else did it and got away with it. The Cowboy Approach. How many of us have seen colleagues do that? We need to avoid recommending a therapy or a procedure because it's possible without thinking through whether it's really necessary. That's what I call knee-jerk management. We need to avoid deciding to proceed with a line of management that involves some hazard without discussing it with the other members of the team and reaching a consensus on management. That is, avoid unilateral decision-making. We need to look to those who give us good examples, but let me just quote one more adage which I have always liked, but I don't know where it comes from, which is, be not the first to take up the new, nor the last to give up the old. The role models, some of our young and our older colleagues, the James Somervilles and the Bob Freedams for their wise counsel, the great leaders in the field, and those who exhort from us the highest standards. May we learn from their example in the pursuit of excellence for the best interests of all our patients.